part of it, which will be excreted in, some of it is in saliva, which is good. Some of it, most of it will go in the urine, some of it in the bones, etc., etc. So unless we have a water fluoridation system of the drinking water, it's impossible to keep the plasma fluoride levels stable, and that the best benefit for the formation of tooth will only happen if ameloblasts have a stable supply of fluoride. So I'm just going to close that part, and for those of you who just started joined us, next week we will start as scheduled with the prosthodontics fixed. Some people don't. Some people have, I think, the RPD, and some people don't. If you're wondering what does that RPD document look like, this is the first page of the document. That's the second page. So removable prosthodontics, about I think 20 pages, and then RPD, removable partial denture, for about 20 pages, then about 2-3 pages of complete denture, and finally some pages for dental materials. So I'm going to close this one and focus on the orthodontic questions. Some of them are similar, or I want to say like repeats, and that's most likely the reason that I kind of put them to the side. And the other part, the other half, are weirdly formulated questions that may or may not be, oh, this is the final answer. I mean, like, this is very easy. This is the answer. We'll still have some doubts in there. So first question says, the treatment of a class 2 division 1 malocclusion has the best prognosis when? I would say, like, okay, you know what? I'm just going to hide all of those options and just what comes to my mind when I think of class 2 division 1. Class 2 division 1 is an anteroposterior problem that may or may not be a skeletal problem. Engels said that it's a class 2 when the mesiobuccal cusp of upper is in more anterior position compared to the buccal groove of lower. So he's only talking about a dental parameter. The dental parameter may be present because of teeth moved, and you guys saw how, like, that patient who had an upper premolar completely in the palate, the upper molar had drifted into the place of the upper 5 because of early extraction of deciduous tooth, and this was just unilateral. On the other side, they had just normal class 1 angles. By the way, in that situation, for that person, the division would be a subdivision. So it would be something like class 2, division 1, subdivision, this is my right side, so subdivision right. Okay. So anyways, another situation would be where the class 2 is because of more prognathic maxilla or more retrognathic mandible. And in that case, the treatment may be simple if we started with an appliance in the pre-pubertal growth spurt, or maybe so severe that it needs to be a surgical case when the patient stopped growing. All right. So again, in my mind, the best prognosis for a class 2 division 1 is when the problem is just a dental problem, and I can just move the teeth, and once I bring back the teeth to their original normal position, everything should stay in place. If I need to move the bone or guide the growth of the bone, maybe the bone follows my guidance. Maybe it's too late. Maybe the patient doesn't follow. They don't wear their appliance for the time needed. There's just lots of things that can complicate things, okay? So a dental malocclusion is always easier to fix than a skeletal malocclusion. If I have a dental problem and say, for example, that anteroposterior problem of class 2, and at the same time I have crowding, so I have to make sure that I have sufficient room, it just adds up to the complication, to the complexity of the treatment. So if I don't have any tooth size, arch size discrepancy is actually better, and then the treatment is easier, and then the teeth will again like stay in place and not try because everything was crowded. I made the arch bigger. Maybe it's stable, maybe it's not, maybe it relapses. Okay, so skeletal discrepancy is more complex to treat. Cases with dental problems, including or added to the list of problems, crowding is more complex. So now let's see what is there in, oh, one more thing. For a case of habit, the longer the habit is there, the more intense, like for a longer time the habit is there, and for a long time of the day that the habit is being done, all the muscles and even the skeleton will be following, like the functional matrix theory, following the need for that habit, or distracting the mandible, constricting the maxilla. Then the muscles are, they pull in that direction. So even if the habit is stopped, there are chances that the musculoskeletal system is still doing the same motion or the same posture, but without, say, for example, the thumb in the mouth. Although the thumb is not there, but everybody's still programmed of doing the same thing, which means that there's still some stress falling on the teeth and relapse can happen. Okay, so skeletal discrepancy is more complex. Crowding is more complex. Habit that has been extensive is more complex to treat. Let's go back there and see. So there is a labial tipping of the maxillary incisors. I mean, that's a good thing. I mean, it's a dental problem. I can just always put them back into a normal overjet. There is a satisfactory relationship of the maxillary and mandibular apical bases. That's amazing. So one less thing for me to worry about. One less complexity to add. So it's more of a simple. There is no arch length tooth size discrepancy. I don't have to add to my list that I have some. Do I extract, or do I just expand, or do I do IPR? What do I do? Is option D more better for question 1? As per best prognosis, there may be more overbite, which is better. There may be open bite too. So I don't know whose iPhone. But why just pick one side of the deal? Why is it the deep bite or the open bite that you picked? So if you give me, say, for example, I'm not so this is directed to me. So you don't see the question. The question is saying, in option D, which is this one, short lower face height, there may be more overbite, which is better to treat, class 2. So say, for example, a short lower face height with the class 2 div 1 can happen. Like, I mean, div 1 can have deep bite, open bite, and none of the above, or like normal vertical, no vertical problems. Okay, so don't pick one. Right, don't just pick one. If you want to pick specific scenarios, you have to talk about all scenarios. So anyways, No, it's not about the open bite and the deep bite. Generally, it's harder to treat cases of open bite and it's harder to treat cases with long face. So, why is someone drawing on my screen? I see a green line here. What are you guys doing? How do I remove this? Draw. Eraser. There you go. So, what was it again? Dolichofacial and something brachy. Not important. Not gonna come in the exam. But anyways, here it says something about dolicho long, brachy short, the different underlying vertical facial patterns develop with considerable facial rotation, mandibles in brachyfacial pattern tend to rotate forward. Yes, we know during growth. This is just copying, you know how books are sometimes, like the paragraph is not continuous. There's a picture diagram in the center, so I just copied the part of the book which you guys are missing. So then it says this occurs in subdivision 2 to the backward rotation tend to move the lower incisors away from the upper structures to develop class 2 division 1 malocclusion, with the lower incisors developing well behind their uppers, which means that the patient will have a more of a class 2 look. Whereas in the patient who has the short face, where did they go? The patient who has the shorter face, not necessarily with a deep bite, maybe just like a short lower anterior face with 30% of overbite, there is less chances of them looking facial parameters wise as a class 2. It masks the class 2. Whereas in a longer face, the mandible tends to go back and back and back and back with growth. So it looks more like a class 2. Is lower facial height in regards of mandible only in the question, or they regarding the maxilla too? So the question is like, what is lower face height? So I don't have the PowerPoint open, but I'm going to just put face and try my best to get a diagram. So the face are the vertical facial relationship will be from Nasian point. So forehead towards the Nasian, this is the upper face. I don't know. Nobody ever talks about it. I've never seen it in books. They always talk about the middle and the lower. So anyways, from point B, soft tissue, to Nasian, that's the middle. And then from it's not really, it's from point A to Nasian, and then not from point B, from just below the chin, which now I think is like the soft tissue pogonian. Don't, please check the handout. So the facial thirds. Then you have here normal mandibular plane angle, normal face height. The normal face height is the lower is just a slight bit bigger compared to the middle. And this is a flat, and this is a steep mandibular plane angle with subsequent short lower face and long face. Okay. So for this girl, for example, I'm gonna say I think I'm not sure, but she could be a class 2 division 2. It does seem that point A is more in anterior position compared to the point B. So just layman's analysis, I'm gonna say like I don't think she has a class 1. I think she's a class 2. And I think she's maybe a class 2 division 2 because it seems like her nasolabial angle is a little bit obtuse. It might be that her teeth are lingually kind of thing. Okay. may be wrong. She may be, but anyways, for this patient, the more that you open her mouth, the more that you bring the face to a longer face height, she's going to look more and more and more and more like a class 2. So which brings us back to that question. Where did it go? Is it better to have a short face working with a class 2, or is it better to have a long face working with a class 2? It's better to have a short face. Okay. And that's just like a general rule. There may be so many things complicating, crowding and deep bite, but I am not going to go into that, like certain scenarios and different scenarios. I'm just going to take just okay, shorter face usually does not show that discrepancy so much, whereas on the other hand, the long face accentuates the discrepancy of AP, anteroposterior. All right, so I hope that's fixed now. In a child, correction of the bilateral posterior constriction of maxillary arch has the worst long-term prognosis. Why should it have bad prognosis? I should have good prognosis. It's not that hard to use the rapid maxillary expander in a child. I can even over expand, and then if anything, like if the teeth are not, after some time the teeth will align into the proper position. I should have the occlusion interdigitate and the buccal cusps of upper overlap the buccal cusps of lower. How can it ever have like bad prognosis? It never has bad prognosis. I I haven't seen a crossbite and posterior crossbite which was fixed and which had overlap, unless you only reach to edge, then definitely it will relapse. But if we go for overlap, then it's not going to come back. So so when would it overlap? If I have some, or when would I lose my retention? If I open the mouth again. See, like the acrylic things that you use to, the blocks in order to open the bite, in order to move the teeth. Once the teeth are out there, you just remove it. They have to interdigitate. Now, if they interdigitate, it's not going to constrict again. So the only way that it can relapse is actually that opening, and then so maxilla can find its way back to edge, and finally to, that's it. So a quad helix, the maxillary posterior teeth are centered, the functional shift of the initial maximum. Okay, there is a functional shift from initial contact to maximum intercuspation. Good. But if I fix the shift and then I expand the maxilla and the shift is gone and the teeth are in interdigitation, there is no way that this can relapse. And by the way, they didn't say anything. This is a habit and D is a habit. If C is a habit, then maybe they go back. Maybe the muscles are programmed. It's going to shift again. But is this a prolonged habit? No. The only one that they said that is a prolonged habit and may come back, we don't know. Maybe the child, I don't know if this is like a history of prolonged or history and stop, but the only thing that can make that crossbite come back is space. Hope you guys agree. So, I'm going to skip and go all the way to question 6. Correction of a bilateral posterior constriction of the maxillary arch has the best long-term prognosis for stability if, and I just said like it should always have a best prognosis. It should never ever relapse. If I do it right and I think it over, is this is the culprit of the like stop the habit, bring them into maybe a little bit of um, overcorrection, let the buccal cusps overlap. Why should it like why shouldn't it always have a best long-term prognosis? It should have a very good prognosis unless I didn't correct the functional shift, I didn't correct the habit, right? So here it says that's like a negation phrase, so you should be careful if they say like that, make it opposite. There is something or it's not there. So if if the habit is there, it is possible that things go wrong. So I'm definitely not going to pick this. This is a bad thing. This is a bad thing. I just picked that this is a bad thing, and I said it's the worst. So there is a history of prolonged thumb sucking. There is a possibility that the child still puts their finger in, and then they open the bite, and then the correction relapses. So the maxillary teeth are centered on the alveolar process. I'm not so sure what you guys are mean. Like this is means like the teeth are in the right place. Is it before? Is it after? I don't know. Like even if it's before or after, if I do the maxillary expander and expand the maxilla at the right time, should be everything is okay. Slow fixed expansion quad helix, why not the rapid? I'm not so sure. Like, you know what, like I don't think it's the type of appliance. This is not going to be a question where I'm going to pick a certain appliance and say, hey, this is the best. But if they say there is no reason for things in the neuromuscular system to be pushing in the wrong direction and trying to undo what I just did, I think this is the right answer. Please let me know if you have doubts regarding the question 2 and the question 6. Okay, so far so good. So let's see what about question 3. When a mandibular second molar that has tipped mesially following extraction, the adjacent first, I guess the adjacent first is uprighted by, anyways, the 4-7 is being uprighted. Don't know why I have like example fixed appliance on 4-7. 4-4 and 4-5 and 4-3 are going to be the anchor unit. The following tooth movements usually occur. The extrusion of the second molar I highlighted in bold. This is the one that you will always have. And then the rest of them, they can be prevented by good planning. So lingual tipping of the second molar can be prevented or corrected by good planning. Intrusion of the anchor unit, if we have sufficient anchor unit, if we're not trying to move a very big rooted, like very long rooted second molar with short rooted premolars. If we find that no, this is not going to work, we should add, I don't know, like another anchor. I don't know if TED would work for extrusion for uprighting. I don't know. Maybe elastic on the top. I have no idea. But if we think that the anchor unit is going to intrude, we should not do it. Or we should reinforce it with more anchors. And then intrusion of the anchor unit, buccal tipping of the anchor unit, again, the same thing. We'll try our best to avoid this. We put it into consideration. It's not like it's not there. Anything that we're trying to do to push that molar is going to have the opposite effect on the anchor unit. It's just that if we are careful, we pick sufficient anchors so that they don't move, that they are able to push that molar without significantly being altered in any way. So the concept here is that we can prevent the other options from happening. Absolutely right. Yes. So the concept here is that the options here, like the 1 to 3 ABC, the older design of questions, you had to be really, really careful about is it will happen or could happen or may happen, or include everything or eliminate. And unfortunately, the questions, because they have released them many times, there are different versions of those questions where probably the person who was making the question was um, like adjusting and changing some word, and then if one word is changed, your answer. So if here it's like, which of the, I don't know, just make it very simple. During the uprighting of a second molar, what should be your concern? I should be concerned about the tipping of the anchor unit, the intrusion of the anchor unit, the lingual tipping of the molar, the extrusion of the molar. So all of them. Okay. And by the way, anything that like I intentionally left the answers, anything that I've put as like a gray is like I am not so happy with my option. I will pick, but I'm not so happy with the option. So let's see about the Bolton relationship. The Bolton relationship determined a maxillary excess of so and so, and a maxillary excess from from canine to canine. There's 3 millimeter, and then from molar to molar, there's 3.5. That means that in the premolar area or in the buccal segment, there is only a discrepancy of 0.5, not so much. Most of the issues is in canine to canine on maxilla being too big. So Dr. Bolton and associates, they had studied, what was it, just what is the correct ratio between the width of the upper and the width of the lower. Not necessarily did they have anything to do with what later on was used for their like using their studies. Okay, let me just see if PowerPoint and orthodontics. Because I think we skipped that slide a little bit. Where did Dr. Bolton go? There. Okay. So bring this one up. First say hi to the cat. And then I'm going to close that. So they said that if you have maxillary teeth that are 100%, or let's say this size, then you need about mandibular teeth that are about 77% of the width of the maxillary teeth in order to have the correct alignment and to have the correct overjet and overbite. Otherwise, putting the maxillary teeth in the right position and having nice overjet and overbite is not going to work. Okay, so there is a ratio between the width of the canine and incisors on maxilla and the canine and incisors on mandible. And they also studied the same ratio from molar to molar on both arches, and the ratio there is pretty similar. So this is only, a difference of 10%, whereas here it's a difference of 25, 27%. So what did other researchers do? They tried to see if I have a mismatch of the ratio, what will happen to the overjet and overbite. And it says here that this is copied, this is copied from review article, and it says if we have excessive maxillary teeth, so which means basically if we have bigger maxillary teeth and smaller mandibular teeth, what will happen is that we will have increased overbite, increased overjet, so the maxillary teeth may flare out a little bit, the mandibular teeth will retrocline a little bit, they will be crowding in the maxillary arch and spacing in the mandibular arch, lingual version, so lingual version of the upper incisors and proclination of the lower incisors. All right, so the maxillary teeth will try to move lingually, and the mandibular teeth will try to flare out and reach them. Okay, so if I escape and if I bring this question, make it maybe bigger. So based on this review, it says that if we have maxillary excess, which is more of the maxillary teeth compared to, so the ratio would be, say for example, 60% or 60%. So wait a second, we divide, yes, 60%. We divide the mandibular teeth over the maxillary. Then we should have increased overbite and increased overjet. Some of those questions, they don't work with the reference. Bring this one back. Put it back in place. And let's say increased overbite, increased overjet, maxillary crowding. Increased overbite, correct. Increased overjet is 4. So how can I pick 1 and 4? I can't. So does NDB believe that it's reduced overjet? I don't know. So where do they have references from? There isn't. Why not add option to maxillary crowding? I'm not happy with 3, so it's not like, okay, let's add one more. This is the reference. This is the only reference that I was finding. So increased overjet, not reduced, and increased overbite. And I'm not so sure if I added all the references for so let me see, Bolton, in your the Bolton analysis, Bolton ratio, no. Okay, close this one, go to documents, and again search for Bolton. So you'll find Bolton. This is just one article. I'm pretty sure, like, I collected a dozen. So that's how to do the analysis, how to measure teeth. No highlights here, no problem. I don't really need this one. Close current tab. So now another question. Retroclination of maxillary and proclination of mandibular should reduce the overjet. Well, it tries to reduce the overjet, tries to camouflage the overjet, but it does say maxillary crowding happens due to maxillary excess. Yes. So all I can say is whoever tried to put this ratio into a study and then observe what is there. It's an observation. People who have maxillary excess have the following, and most of them had increased overbite, increased overjet, crowding maxillary arch, spacing in mandibular arch, lingual version of this, and labial version of that. Okay. So does Grabber have this in the book? No. Does Moyer have it? No. Does what else there we have? Didn't achieve AFK other NDB review books. Where's this is the reference text. And if we check all the reference texts of orthodontics, they don't have it. Okay. So let me just open here, Bolton. Yes. So Bolton, 1958. Bolton, 1962. Bolton articles collect. Bolton 1, Bolton 2, Bolton 3, Bolton 4. Let me just. I want to delete them. Okay. So that's it like that. I'm just going to stop here and I'm going to tell you this does not work. We should be picking 1 and 4 and 2. So 1 and 4 and 2. This and maxillary crowding is correct. A significant factor in the correction of an anterior crossbite is so the first thing that you want to check for is the space availability mesiodistally. Shape of the teeth, no way. Depth of the crossbite is only important after we finish, right? So this is the significant retentive stability factor. This is the stability. It does not relapse, right? Age, no, it's okay. We can treat it at any age. This one we already discussed. The effect of chronic nasal restriction on mouth breathing is difficult to evaluate. I think this is repeat. If not, I don't know. We probably did discuss it some during the course, but maybe not with a question. So breathing. Breathe. I can't see what I am typing. Breathe. Respiratory pattern. It seems it could, if these is just postural, if it's maintained for a long time, maybe it seems it may contribute. Difficult to indict as a frequent etiologic agent. Difficult to, I think indict is like, this is it, this is the culprit. So, crowding of the lower incisors following orthodontic alignment can be prevented, yes, but the removal of the third molars, no. Can be prevented by wearing retainers until the mandibular growth is complete. It's not a wrong statement. It is just an inaccurate statement. But I eliminated it before. Yes, I know, but I don't feel the need to eliminate it here. I mean, it can be prevented for if we wear it until growth is complete, but then we don't really know when growth is complete. and definitely we cannot predict it from the characteristics of the original malocclusion. Okay. The occlusal parameter most likely associated with maxillary anterior spacing is the accentuated maxillary curve of Wilson. Where is that handout? Let's see. So the Bolton or Bolton concept that rule the things that I was just mentioning, this is not me, this is copied, okay? Whereas the part that I'm about to talk about, which is the curve of Wilson, is something I had to just, like, I'm not so sure what you guys are talking about. I tried to look it up everywhere. It was not there in any book. So I'm like, okay, let's just imagine what would happen. And I was like, okay, if I have here the reverse curve of Wilson, I'm most likely going to have, so this is again like, look, the reverse, sorry, the reverse curve of Wilson. So with the reverse curve of Wilson, I would expect to see the maxilla is constricted, and for that, so normally it's you could see that the teeth maybe they flare out and spaces between them. So if I go back to that question, so the occlusal parameter most likely associated with maxillary anterior spacing. Maxillary anterior spacing, well, if there's peglateral, if there's small teeth, sure. There is no specific parameter, especially a posterior parameter that would give you an anterior spacing. Class 2, Division 2 dental malocclusion, no, it's usually retrocline teeth. Class 3, skeletal malocclusion, not necessarily. So sometimes the teeth are behind the mandibular teeth, other times it's edge to edge, and other times they're more in a forward position and they are flared, but not necessarily. So if they are behind the teeth or in crossbite, you don't have the spacing. 2, curve of Wilson, so accentuated maxillary curve of Wilson versus their reverse maxillary curve of Wilson. Trying my best. Maybe this one is better explained in class. So if you have maxillary arch, which is this is normal curve of Wilson, and then try to bring this to a more accentuated, you'll see, I'll have to open the, and then I have to see myself. Where am I? There I am. Okay. And then, so imagine that the teeth, okay, they have this convex curve of Wilson is convex. If and I need a paper for this anyways, so if I flex it a little bit more, the tip of the incisors and the buccal teeth, they will flare out. If I make it even more convex, they will flare out. So, and like I said, this is not anywhere in any book. As far as I looked, there was nothing there. So this is just a conclusion from me. 8:30. Okay, you guys. I'm not so sure if you have questions regarding this one. I'll try to better demonstrate it with maybe a paper in class. Do you have any questions regarding the other 8 questions? In chat, I can see that this point is mentioned in the notes. Yes. Okay. Oh. more.
Recording stopped.
So I'm not receiving any issues with the patient management. I hope you had the time to review patient management and to review orthodontics. So the first half of the week is usually you reinforce the part that was studied before, and that's super important, even more important than starting the next topic. Okay. No problems with ortho. Close this one. New pedo. What topics would be discussed in the next class? This handout. So what is there in this handout? Maybe we can, I think the class is supposed to be 7:30 to 9, or is it 7:30 to 8:30? If you remember, please let me know. Oh, that's the part that we're going to be discussing next time.
Recording in progress.
Recording. Mention the time. Didn't mention the time. Okay. So I think, you know what, like for today, we'll call it the end of the session. I'll just introduce the handout, what we're going to be discussing next time. So we'll go through the rules of fixed orthodontics. Why is it important? How about ceramics? Some people said like, okay, the ceramics is smaller. Some people don't have the handout of RPD, and so within the next 2 weeks, you'll have ceramics, RPD, complete denture, and fixed orthodontics. And for those of you who have received all the handouts, good. Give me a second. You guys, everybody's here now. Everybody's here now. Does everybody have, like, I can see 15 people still there. Do you have this handout? Give me a second. So I have a PowerPoint, and the ceramics. Do you have this handout? Or other way around. If you don't have it, please let me know. It seems like everybody does. Does anybody not have the ceramics? Not have the ceramics. Okay. Everybody has ceramics. You sure you want to stop recording?
Recording stopped.
Okay. So if everybody has the ceramics handout, we'll do ceramics next time. Ceramics, color, sheet selection, all the way to the casting issues. So the whole handout, we'll go through the whole handout. We will receive, for those of you who don't have the RPD, where did the RPD go? I closed it. So if you don't have RPD, because I'm only going to make some copies, not like, I'm pretty sure everybody has them. If you don't have the RPD handout, which is this one, here, which is 42 pages, not including the the cover page. So if you have something that's like a document, Word document, then perfect. If not, please let me know. I will have to make a copy for you. Okay. And next time we will do ceramics. If we have the time, we can together go through the first few pages of RPD. Okay. So please review ceramics. Questions of prosthodontics. Maybe we'll do them on the Wednesdays on like the Zoom. Okay. All right. Okay. So no fixed and I'm not coming this Sunday. People are like, okay, this one and that one. I'm like, no fixed. If it's possible, let's do the ceramics. Okay. So for next time, we have, if everybody has ceramics, please have a look. We'll go through the ceramics handout. Anything in particular? At this point, don't memorize, just read. At this point in time, don't even try to memorize, okay, the polysulfide contains, what was it, the lead. Yes, it has lead. Where is it? Constituents, lead oxide, oleic and stearic acid can change it. All right. All right. You guys take care and see you on Sunday. Okay. See you soon. Take care.